also in the same apheresis field. Dr. Khan is standing there, and she will start, yes?
Okay, thank you. Good morning. It gives me great pleasure to talk about my research in which I looked at whether apheresis can be considered a novel treatment for those with refractory angina in the context of raised lipoprotein a, but in the absence of significantly raised LDL cholesterol. And I performed a randomized controlled trial. Here's a list of our investigators on this research, and disclosures are also provided. I personally have no declarations of interest that are relevant. So to provide a bit of background, refractory angina is angina that continues in spite of optimal medical therapy and revascularization techniques. And it is very challenging to manage and causes a lot of burden for patients, and we desperately need novel therapeutic options. Raised lipoprotein a has been well established with a multitude of epidemiological evidence to be an independent cardiovascular risk factor, and it can be effectively reduced by lipoprotein apheresis, and frustratingly, it cannot be treated in a satisfactory way by our conventional lipid-lowering therapies such as statins. Raised lipoprotein a may be prevalent in refractory angina, given that it is such a strong cardiovascular risk factor. And although there is plenty of evidence that lipoprotein apheresis is efficacious in familial hypercholesterolemia, which my colleague Professor Moriarty has alluded to, there is very little randomized controlled data looking as to whether it should be used for patients with raised lipoprotein a. And certainly there is currently no randomized controlled data assessing the clinical benefit of lipoprotein apheresis in patients with refractory angina and raised lipoprotein a. These are our declarations of interest from our research group. As I said, I personally have no conflicts to declare. So what is the purpose of our research? Well, we set out to determine the effect of lipoprotein apheresis on fully quantitative myocardial perfusion or myocardial blood flow using cardiovascular MRI. I also used CMR or cardiovascular MRI to look at the carotid atheroma burden. I looked at exercise capacity, angina symptoms, and quality of life in patients with refractory angina, and raised lipoprotein a elevated above 500 milligrams per liter. My trial methodology was of a randomized controlled trial with crossover design in 20 patients with refractory angina and lipoprotein a elevated above 500 milligrams per liter and LDL cholesterol of less than 4 millimoles per liter, although our baseline mean LDL levels were considerably lower than that. And the patients were randomized to either 3 months of blinded weekly lipoprotein apheresis or sham treatments, followed by crossover, and there was a 1-month washout period in between. My primary endpoint was change in quantitative myocardial perfusion reserve, which is a ratio of quantitative stress perfusion to rest perfusion by cardiovascular magnetic resonance imaging using very advanced techniques. Our secondary endpoints included measurement of carotid atheroma burden, again by CMR, exercise capacity determined by the 6-minute walk test, angina symptoms as determined by the Seattle Angina Questionnaire, and quality of life assessed by the SF36 quality of life score. In terms of results, my primary endpoint, which was myocardial perfusion reserve, increased by 0.47, 95% confidence interval 0.31 to 0.63, from a pre-apheresis level of 1.45 to a post-apheresis average level of 1.93. But it decreased during sham slightly by 0.16, 95% confidence interval of minus 0.33 to 0.02, from a pre-sham level of 1.63 to a post-sham average of 1.47, and this yielded a net treatment increase of 0.63 with a p-value of less than 0.001 between groups, showing that we got, despite our small sample size, we got a highly statistically significant result in terms of our primary endpoints. Additionally, in terms of my secondary endpoints, I saw statistically significant improvements in the exercise capacity determined by the 6-minute walk test distance, angina symptoms in terms of positive statistically significant results for 4 out of 5 of the Seattle angina domains, and quality of life, specifically the physical component score of the SF-36. And I also saw a reduction of carotid atheroma burden. In conclusion, in patients with refractory angina and raised lipoprotein a, in the absence of substantially raised LDL cholesterol, apheresis led to statistically significant benefits in myocardial perfusion, carotid atheroma, exercise capacity, angina symptoms, and quality of life.
Thank you very much.
Thank you.
This presentation, Apheresis, is open for your questions. We have a question there at the second row first.
Yes, Demicron from local Minister has mentioned before apheresis is very invasive and difficult procedure. Do you think that the result you get justify the eventual loss of quality of life implied by apheresis itself?
I think it's possible that it may, not just based on my trial, but there have been 2 observational cohort studies that actually documented a sharp decline in MACE events. So I think for the future, what one needs to do is a cost-effectiveness analysis to balance looking at the costs of the apheresis versus the sharp reduction that we are likely to see in terms of MACE events, PCI costs, coronary artery bypass costs, and recurrent readmissions for these patients with refractory angina. So I think we will have the answer once we run a cost-effectiveness analysis looking into this.
Next question. Okay. Just see, was there any further questions in the back? Then we take the lady up front here.
No.
That's okay. No, that's fine. Just.
What proportion of patients with refractory angina will actually have raised lipoprotein A?
That's an excellent question, and I can partially answer that from my screening program itself. And I fully disclose that we're not dealing here with large numbers, but I screened close to 100 patients for this trial, and I carefully documented the lipoprotein A levels for every single patient. And in fact, we impressively found that 60% of the patients that I screened for this study had levels above 500 milligrams per liter. So we were even surprised by the large percentage of the patients with refractory angina who actually had raised levels.
Yes.
If I could, Crystal Fine with MedPage today, if I could follow up on that, but won't most people with refractory angina have increased or elevated LDL? Aren't you looking at a smaller subset of people without elevated LDL and then looking for elevated?
Sure. So, some of the patients in our, just a few of the patients that we screened did in fact have FH as well, so they ended up being excluded. But I have to say that that wasn't a huge percentage from the patients that we screened, but that's a good question that will need to be looked at in the future.
Okay, so overall in refractory angina, is elevated LDL without looking at lipoprotein a, is that, will most people have elevated LDL?
A lot of people will have elevated LDL, but usually it's well controlled with statins, and that's the difference here. The key difference is that what I saw was that these patients with terrible refractory angina were completely resistant to revascularization and the standard statins. They continue to get angina, possibly because of elevated, very high levels of lipoprotein little a. Most patients will have their LDL cholesterol controlled with statins or conventional therapy. The FH group represents a rather small cohort
So
overall.
what's going on with the lipoprotein little a that's causing this then? What's the mechanism?
I think the mechanisms are numerous. I believe that it contributes to microvascular dysfunction. I think it also causes endothelial dysfunction. It also increases plasma viscosity, which we can reduce with lipoprotein apheresis. And it also has impacts, it has prothrombotic effects via numerous mechanisms, which I won't go into a lot of detail, but there are multiple ways in which it causes you to clot more readily. And in addition, it actually adheres to the intima, and some believe that it actually binds to the intima more aggressively than LDL cholesterol itself.
Ladies and gentlemen, our time is almost up. The speakers will hang around for personal questions.